I'm going to talk about three different aspects of treating secondary CNS lymphoma, data from the last few months, really at EHA, at ASH in December 2019, and also that was going to be presented at BSH, the British Society of Hematology meeting at the end of April. So secondary CNS lymphoma, as you know, can have a really dismal outcome, and studies really that have actually addressed the treatment of it have generally involved a small cohort of patients, usually under 40 patients. I want to talk about the Marietta study, IELSG 42, led by Andres Ferreri from Milan, and the largest prospective, it's a phase 2 study addressing the treatment of patients with secondary CNS lymphoma. So, as I said, historically it's had a dismal outcome, and really it's quite complex because there are really sort of three subgroups of patients. So there are patients who present with secondary CNS lymphoma, so they have concomitant CNS and systemic disease, or patients who are treated with R-CHOP, predominantly R-CHOP, can relapse with secondary CNS lymphoma. They may present with isolated CNS relapse, or they may present with concomitant refractory systemic disease and new CNS disease, or relapse with both. So, a very difficult cohort of patients. So IELSG 42 is the largest phase 2 study in secondary CNS lymphoma. It involves 79 patients across 4 countries and 24 centres. Recruitment was achieved in just over 3 years and was completed in 2018. Now, the subgroup of patients involved in the study really were very poor risk disease. So 80% of the patients had concomitant CNS and systemic disease. 43% of patients actually had disease at presentation. So they were treatment naive, but they had concomitant CNS and systemic disease. And 80% of those patients, the whole cohort, had concomitant CNS and systemic disease. Only 20% had isolated CNS disease. So it was very inclusive, included patients up to the age of 70 and performance score up to 3. So really a sort of relatively real-world trial data set. The treatment algorithm was very intense, but really it was trying to use protocols which we know are both effective by having agents that cross the blood-brain barrier, but also have evidence in treating patients with both CNS lymphoma, so matrix, but also systemic disease, so RICE. So the algorithm was 3 courses of matrix followed by 3 cycles of RICE with the aim to get to a BCNU thyroid conditioned autograft. So of the 75 assessable patients, half the patients got to autograft, and those that got to autograft had really an excellent outcome. 83% of those were disease-free at 2 years. Now, the whole cohort of patients, the 2-year PFS was 46%, and really that's partly because of the high proportion of patients who actually had relapsed refractory disease, 57%, and a significant proportion of patients who had both CHOP refractory systemic disease or relapse very soon after. So the 2-year progression-free survival in patients who had de novo presentation, their 2-year PFS was 71%, suggesting that Marietta IELSG 42 protocol is really a very sort of effective regimen for this group of patients. Those who have CHOP refractory disease or CHOP, early relapse afterwards, their 2-year PFS was much lower at 28%. So we really have to think about other modalities of therapy, and I'll talk a bit about that later. So in terms of associated mortality with this regimen, it was about 5%. There were predictable side effects of cytopenias, infections, but really, it was very deliverable, and as I say, across 4 countries and 24 centres. So in summary, I can say, the one other thing I would like to say is that patients who were in CR after 2 courses of matrix, that was a very helpful, positive prognostic factor. And that cohort of patients, their 2-year PFS was 85%. So certainly for patients who present with secondary CNS lymphoma, matrix using Marietta using both matrix and RI, aiming to get to a BCNU thyrotype autograft, I think we can say we can potentially cure patients with secondary CNS lymphoma in this setting. And as I say, the cohort of patients where we have to think about other treatment modalities are those who've had R-CHOP or in the middle of R-CHOP and present with CNS disease and concomitant systemic disease. That's really a challenging cohort of patients. All the studies that have been published have had less than 40 patients in their cohorts, either being trial data or retrospective data. And really, we need to think about whether we can actually potentially cure patients who actually get transplant. So this is a data set that's presented at EHA this June, and it's looking at a cohort of patients who get to autograft and looking at their outcomes subsequently. It's initiated by my registrar, Jahanzeb Khawaja, and it's a poster at EHA in the transplant section. So it's an international multi-center retrospective study. All the patients had received thyrotype-based conditioning, and it included 84 patients from centers in Germany and in the UK. Now, patients were up to the age of 77, so clearly a sort of treatment modality we can consider for patients into the 8th decade. About 30% of the patients had had secondary CNS lymphoma de novo, so they'd had no prior treatment. And in this cohort of 84 patients, more than half of them had isolated CNS relapse. So you can see that there's a sort of underrepresentation in this cohort of patients who have synchronous CNS and systemic disease, again, consistent with the IELSG 42 data, that actually to get those patients into remission, to get them to autograft, is very challenging. Now, of this cohort of patients, 80% had diffuse large B-cell lymphoma, and the majority of the other part of the cohort had transformed follicular lymphoma. So all aggressive B-cell lymphomas, and 3% had T-cell lymphoma. So of the patients who'd had prior therapy before their reinduction therapy, 40% had had CNS prophylaxis, and a third of patients progressed within 3 months of their prior therapy. So when we look at autografting with thiotepa-based conditioning, it was relatively well tolerated. 5% had some renal toxicity, 5% some liver toxicity, 95% febrile neutropenia, 7% went to ITU, and a non-relapse mortality of 5%. And as I say, patients up to the age of 77, in actually the de novo group 75 and the relapse group 77, so in both cohorts of patients. The inpatient stay was about 21 days. In terms of outcome for the whole cohort of patients, the 2-year progression-free survival was 70%, and the 2-year overall survival 78%. So really encouraging data. We know for those who have isolated CNS relapse or de novo secondary CNS lymphoma, when they present with secondary CNS lymphoma, their 2-year PFS in both of those groups was over 70%. But again, like IELSG 42, those who even get to autograft, who had presented with relapsed or refractory systemic disease and concomitant CNS disease, their outcome was inferior. They had a PFS at 2 years of 46%. And of the patients who subsequently relapsed post-autograft, only 1 of the 25 was salvaged. So really, again, challenging cohort of patients, and that will really lead me to my final section, where I'm sort of talking about potential strategies to treat this group of patients. Okay, so the challenge really, well, there are many challenges still ongoing, but a particular challenge is this cohort of patients who are R-CHOP experienced. They present with secondary CNS lymphoma. They may be in the middle of their R-CHOP regimens. They may relapse very soon afterwards, and they have both systemic disease and CNS disease. Now, we know from studies including CORAL, also the SCHOLAR data, that if you relapse soon after R-CHOP or you're refractory to R-CHOP, that cohort of patients do very badly if they only have systemic disease. So the situation of concomitant CNS and systemic disease, as we know from IELSG 42, and also from our own transplant data, this cohort of patients are less likely to get to autograft. And also from our recent transplant data that we presented at EHA, that cohort of patients, even if they get to a Thiotepa-based autograft, have an inferior outcome. So, as in systemic lymphoma in this setting, we think about CAR T-cell therapy. So we know from the early studies in addressing the sort of innovative therapy that CAR T really has been seen to be, that ZUMA-1, that excluded patients with either active or CNS disease. The Juliet study excluded patients with active CNS disease but allowed a history of CNS disease. And the present lysogen trials, Transcend, they have got cohorts of patients which allow patients with both active or a history of CNS disease. So hopefully from those studies, the Transcend, we will be able to see some trial data for this cohort of patients. I was really sort of encouraged and really quite excited by some data presented at ASH. So data presented using both axi-cel and Tisogen for patients with secondary CNS lymphoma. So at ASH, there was an oral presentation of 18 patients who received axi-cel. Difficult to draw conclusions because a proportion of those patients, about half, had active CNS disease when they presented for CAR T-cell therapy consideration, and half had had a history of it. Some had bridging in each cohort of patients, some did not at the time of receiving CAR T-cell therapy. Some had active CNS disease still, and others did not. The one thing I would say from that presentation, but also from the cohort of patients of 8 patients at ASH who'd received Tisogen for secondary CNS lymphoma. In both, it's really encouraging because there's efficacy data. It appears in this small cohort of patients that it's a potentially efficacious strategy. In terms of safety signals, we'd had concern that, was there going to be a greater neurotoxicity incidence, and that has not been realized. It doesn't appear to be that there's either higher CRS or higher neurotoxicity compared to other settings. We also know from the real world data, so again at ASH and in other settings, the CIBMTR data is really helpful. So really over 500 patients who received axi-cel and also a considerable number that had received Tisogen, and a significant proportion of those patients wouldn't have fulfilled criteria for their respective trials. So didn't fulfill criteria for ZUMA-1 or for Juliet. And reasons for that are many, but in both cohorts of patients, the reasons include secondary CNS lymphoma. So I haven't seen data for those sort of respective, but I've seen sort of anecdotal reports from both to suggest that, again, patients with secondary CNS lymphoma appear to respond to CAR T-cell therapy when they've had history or active CNS disease in the setting of both systemic and CNS disease. And I look forward to further data, both from clinical trials and larger retrospective series. So as I say, it's a challenging field to be involved in, but it's also really exciting as we sort of identify new strategies. And I really feel encouraged for our patients that I think we can talk about potential cure for secondary CNS lymphoma, certainly those who present de novo, thinking about Marietta, matrix RICE autograft for those who are treatment inexperienced. And again, I think of sort of a similar regimen for those who have isolated CNS relapse. But patients who have, R-CHOP refractory disease systemically and have concomitant CNS disease, that's a much trickier cohort. And again, whether it's CAR T-cell therapy or will there be new other therapies, we just have to think about the fact you want therapies across the blood-brain barrier, but being aware that concomitant systemic disease is also a challenge in your whole treatment algorithm.